Okay, so it's about a Sievers type 2 bicuspid aortic valve. As I said, it's a female of a 76-year-old with a NIHA score 2 to 3. And from her past medical history, she suffers from arterial hypertension, dyslipidemia, and pulmonary hypertension with a BMI around 42. The baseline creatinine is 0.77 with high surgical scores. The patient has no significant coronary artery disease, and the screening echo shows an LVF of 60%, an AVA of 0.8, and an increased aortic valve pressure gradients with an RVSP of 55 millimeters mercury. Here we can see some videos from the screening angiography. We can see the left coronary artery. Unfortunately, we were unable to find the right, so we proceeded to a CT angio in order to find a patent coronary artery. Here you can see the measurements from the screening echocardiography with an increased aortic valve velocity and some valvular regurgitation in the left picture. In the right picture, in the right video, we can see the restriction with the aortic valve opening. As we can see, the left ventricular ejection fraction is preserved. And according to the CT angio, the valve appears to be bicuspid, Sievers type 2, heavily calcified, with the calcifications extending from the annulus to the left ventricular outflow tract. On the left, we can see the extent of the valve calcification, and on the right diagram, the Sievers classification for the bicuspid aortic anatomy. In our case, as I said before, we have a Sievers type 2 with 2 raphe between left to right and left to non-coronary cusp. Furthermore, we can see a dilated ascending aorta, the calcium extending from the annulus to the LVOT, and a calcified hypertrophic aortic annulus. As we can see, the angle is 70 degrees. There's absence of severe peripheral artery disease, with some tortuosity, though, in the femoral arteries. Proceeding to the valve selection, through CT angio, we selected the 29 millimeter Evolut FX. The heart valve team of our hospital decided that transcatheter aortic valve implantation should be the optimal strategy with a Medtronic Evolut FX 29 millimeter valve. So moving on to the procedural steps, we have right radial and right femoral artery puncture under echo guidance, pigtail from the right radial and sheaths through the right femoral artery. Stiff wire Landerquist, pre and post dilation with pacemaker introduction due to conduction abnormalities. See also the closure device we used for style. And now we can proceed to the video of the case.
Yeah, feel free to fast forward some parts of the video to save some time, okay?
In the beginning, I'll be very quick. In the beginning, we have the puncture of the right femoral via under echo. Here, the advancement of the peristyle. Here we can see the pigtail introduction from the right radial artery, and we can also observe the heavily calcified aortic valve. Here's the introduction of the AL catheter inside the left ventricle. And here we have the balloon from the pre-dilatation with rapid ventricular pacing.
Remind us the size of the balloon.
29. The balloon? The balloon, 20.
20 balloon, yeah.
Here we advance the valve. It's a difficult implantation due to the extensive calcifications at the annulus. And here we perform the first attempt to open the valve.
While playing the video, can you tell us a little bit more why you select this type of valve? Any advantages that you saw, disadvantages compared to other valves?
The question is,
and this specific self-expandable versus others?
Actually, this is the part that we have the most experience with. It's a bicuspid valve. You have to pay special attention to the opening force as well as to the radial force. So it's the one that has from the self-expanding platforms, the more open force. So we are dealing with a lot of calcification extending to the LVOD. That's why we're reluctant to predilate a lot. You see, as George said in the previous, in his presentation, these are the patients with bicuspid valves with relatively enlarged the aortic root. So maybe if these patients don't go, the outcome is not as optimal as other cases. So we chose to be conservative in this case. We predilate with a moderate size balloon. We always use the screening CT to identify the proper sizing of the balloon, and then we had, of course, to deal with the post-dilatation. And you can see here, how the opening is really, I would say, dramatic, and with some recoil at the end of the ballooning. So, George, would you use another valve? Like, do you use? Do you have a go-to type of balloon to use in bicuspid situations like this one? Do you use a balloon expandable valve?
I mean, I have to say that the 70% orientation and you might use it, the self-expandable valve, but at the same time, with this heavy calcification and eccentricity, you have higher risk of rupture versus you're doing this stepwise approach with this type of valve, you avoid that part. I'd like to hear Dr. Finkelstein's opinions about this procedure. Keep fast forward the procedure. I want to see the aortogram after the, the final aortogram, and then Dr. Finkelstein. Okay, please find a way that we can see Dr. Finkelstein and see the screen as well from AV control. I want to see both. Well, then, okay, Dr. Finkelstein, hello, keep talking. Let's go back to the screen so we can see the case. Thanks for connecting with us. We hear you, Eric.
Hi, guys. How are you?
Very well, very well. I hope you're well also.
Well,
and all the family and all the friends.
Everything is relative in life, Anyhow, I just joined a few minutes ago. But I heard, this is Ioannis, the operator, right?
Yes, that's right.
Okay, so it's a very nice implantation. You cannot argue with success. However, there is something that you both mentioned and I slightly disagree. Nobody can accuse me for not be a fan of the core valve family, the Evolute, etc. But the excuse that bicuspid calcified is not for balloon expandable, I'm like a broken record. I'm keeping saying that you're doing pre-dilatation, then you're doing a post-dilatation. So what's the difference from balloon expandable valve? You did not compromise on less than a perfect result, and in order to have it, you did a post-dilatation with the same balloon that would have been in the balloon expandable valve that you could use. So I don't think that one device is better for this case, but balloon expandable is definitely as good as self-expandable in this case. And regarding this, I think that if you are pre-dilating, Johannes, you should not be afraid of pre-dilatation with a much, much bigger balloon. And I want to remind you, you have an experience of many, many hundreds of cases. I want you to recall even a single case that the pre-dilatation ended in a full-blown catastrophic AI. You know, we are talking about it, we are writing about it. I've seen in my entire career of almost 4,000 cases, only a single case that we had to rush very quickly because there was a acute, huge AI. So I think that if you are doing a pre-dilatation in a case like this, in which you would love very much not to do post, because in a bicuspid like this, you would love to implant it very high. And whenever you implant it very high, you want to avoid post-dilatation. You are a little bit afraid of. So I think that the best way to do it is do a pre-dilatation with a much bigger balloon. Don't be afraid of it. And then the implantation of the self-expandable Evolute, in this case, would be a high implantation with a perfect result at the end.
Arik, so thank you for your comment. So actually, we were doing the procedure in the way that we learned from you some years ago. So I think we were very cognizant of the LVOT calcification. So that's why we're a little bit moderate in the pre-dilatation. I have to agree. You can use balloon expandable valve as well, but in this situation we were actually expecting to pre-dilatation, a high implantation of the valve to avoid any pacemaker implantation, but we didn't, and then to do a post-dilatation as well. But you can go either way. So your idea is if you do you think if you do a pre-dilatation, if you're dealing with a bicuspid Sievers 2, you don't do pre-dilatation with the expandable valve, balloon expandable valve?
I'm doing anyhow pre-dilatation. In a bicuspid, it's a rule of thumb. Do a pre-dilatation. But if you are using a self-expandable, the pre-dilatation should be with a much bigger balloon because, you know, bicuspid is a different animal. And in a bicuspid, you can see the self-expandable, whatever it is, and even with the one with the best radial force, as you mentioned, like Evolute, it never ever opens the bicuspid as you want it to. And the only way it will open it without a need, an absolute need for post-dilatation, is do a pre-dilatation with a bigger balloon. That's what I'm saying. You cannot argue with success. You made a beautiful implantation with a beautiful result. I'm just saying that you can either take a balloon or a self-expandable valve for those cases. The excuse not to use a balloon expandable because it's heavily calcified, etc., is not an excuse anymore, because you do not compromise of less than a beautiful result, and you will do a post-dilatation with a bigger balloon, you understand? That's what I'm saying.
So you mean they pre-dilated with 20, and they placed the Evolute 29, and post-dilated with, which one did you use to post-dilate?
I don't...
26. So
I join you.
how would you alter the pre-deal and post-dial sizes.
I'm sorry, but according to the program that I have, I was supposed to join you only about 5 minutes ago, so I didn't see the measurements of the
Go back to the slide, please, AV control. Go back to the slides and stop the video now. We're good. Go back to your slide that included the measurements and the valve and the valve and the table with the different valve possibilities.
Yes. Sorry, it's Clemencio.
Go to the CT measurement. You come later to this slide, but before, show us the CT measurements, please. One or two slide before. Before this. Before. Yeah.
Okay, that's
Stay here. Yeah.
I don't see it. What is the annulus diameter? I don't see it.
Annulus is 22 by 26. Mean 24. Perimeter 78.
Okay, I would
area
take
450.
I would take a 23 millimeter balloon for predilatation.
So it's yeah.
So would go a little above. It's 22.2, the minimum diameter of the annulus. So Eric would round it up to 23 and use a minimum annulus diameter.
What did you use? What did you use?
He started with 20.
Okay, so I would train 23. And I think it would allow the self-expandable evolute with the radial force to expand much nicer during
a little bit, one more slide after to show the, follow the slide. Yeah, it's still a little bit before. Yeah, this one. So this is exactly the annulus, the way, I don't know, the perpendicular plane. And you can see the various things is, I guess, the perpendicular plane has a, I think they were a little bit, over here, I think someone was a bit concerned about how eccentric this was. And you can see the minimum diameter is 15.8. Yeah, so I think that posed some questions about going with a 20 here. So how would you address the eccentricity and the calcium?
Look, George, you know that what they call in Medtronic best practice, you know, and according to best practice, with, I'm sorry, you know, I'm not going to die of modesty, but we wrote this best practice years ago. And according to this best practice, you are supposed to calculate the balloon diameter according to the minimal diameter. This is history, come on. It expands. And it expands because it is not a rigid calcium that doesn't move with the balloon. So this theory or best practice of choosing the balloon according to the smaller diameter is too much conservative, and this is really history. We're using now a bigger balloon, nothing happens with it, and if something happens to it, it's not because of the diameter, is because of the calcium at the LVOT. This is the only thing that you should be concerned of. These are the only cases that do annular rupture or something. Otherwise, choose the balloon according to the mean diameter.
Very good. Dr. Mezilis and perhaps Dr. Dimitriadis.
Yes, I don't think there's any, regarding the choice, the valve, I don't think there's any advantage of choosing a balloon expandable over a self-expandable. And there's a lack of data in bicuspid valves. But I guess it's a trade-off between, sorry?
Okay, I just wanted to advance the slide. Go ahead.
Okay. Trade-off between running a risk of annulus rupture with a balloon expandable or ending the case with some distortion of the valve or paravalvular leak if you choose a self-expandable. But I wanted to ask Dr. Finkelstein, regarding the choice of valve, would you take into account this supravalvular anatomy as well? Do you measure, if there's a conical shape of especially in this type of valves, and take into account the intercommissural distance when you choose the size of the valve, or you go on basis of the annular diameter?
Now, this is a very important question. I think that we went already to what we call patient-tailored therapy. And I think that, the need for supraannular valve in order to prevent PPM, for instance, patient prosthetic mismatch, is according to the patient, whether it's a small patient or a high volume or higher, a bigger patient, whether it's a young or not, whether you're going to see a need for a future TAVR procedure. So I think that the algorithm today is much, much more complicated and longer and takes into account so many parameters together, not just whether it's supraannular in order to have a bigger orifice area at the end of the procedure. But I think this is an important question because this should be taken into account as well, not just regarding the PVL or annular rupture, but much, much more parameters. You're right.
Okay, Dr. Dimitriadis, can we have your comments?
Yes, actually two different comments. First of all, a big discussion about the two valves. I think there is no comparison between the two valves. Both of them are fine, are good for that situation. I think the big issue is with which valve do you feel comfortable and confident to proceed to such a bicuspid case. There are a few technical different issues. If operator or a team are more comfortable with repositioning of the valve in such a case, then you have to choose the Evolute. If it doesn't matter for you, then you can go with a balloon expandable valve, one shot, and that's all. The second point is, or my second comment is about the diameter of the balloon. I think in such cases, it's very important to go close to the small diameter. 1 millimeter more or 1 millimeter less doesn't make a big issue, doesn't make a big difference. So we have here 22, so if you go with 23 or 21 millimeter balloon, the first predilatation is okay. You have to avoid to go with a bigger balloon because there are some cases also in the bibliography with complications. So go close to the small diameter, 1 or minus plus 1 millimeter, and you will have good results.
Professor Toudoudas is online or not yet? So should we go to the next talk, Professor Toudoudas, and then the live inbox, the other live inbox? Yes. Okay, Dr.